So in last maybe 1 year or so, whatever like interesting, there are a lot of interesting cases of infectious disease we have come across here. But I thought I'll present some of the important cases and the different varieties. So I'll straight away go to our case number 1. He's a 65-year-old retired teacher with underlying type 2 diabetes, and it was well controlled on diet and metformin. He had some eczema. He was admitted with chills, abdominal discomfort, with occasional diarrhea and dysuria, with urinary frequency for a week's duration. So he did not have fever or cough at this point of time. He noted some loss of appetite, but there was no vomiting or any GI symptoms. He was afebrile when on examination, and but when he came to emergency, he was looking toxic. He was alert and oriented. The blood pressure was 100 or 60, and pulse was 90. Respiratory rate was 20. So systemic examination was unremarkable, and his pedal pulses were also poorly fed. So that was the only thing. His the CBC report has shown immediately that white blood cell count was 35,000 with 92% neutrophils. The liver function test was normal except for some hypoalbuminemia. His chest radiograph and sonography of the abdomen was unremarkable. The urine showed some pyuria but no growth of organisms on culture later on. The initial clinical impression was of possibly some kind of urinary tract infection or some intra-abdominal sepsis, we don't know. So it was kind of undifferentiated kind of fever or sepsis. He was treated with ceftriaxone, sulbactam and levofloxacin. Over the next 1 day, he was on high dose of inodos. So within 24 hours, he was in severe shock, and he was not even responding to a lot of IV fluids and and broad spectrum antibiotics as well. And he was on inotropes, that is dopamine as well as noradrenaline, and even he was requiring vasopressors to maintain his blood pressure. His antibiotics were escalated earlier itself to meropenem, colistin and teicoplanin. And at this point of time, he was, we have been asked to see him. So on examination, he, if you remember, he had some kind of eczema, to begin with. So we were actually, undressed him and looking for some kind of any rash or anything. So he had mild, reddish, the eczematous lesion where he was scratching, I think, and it was reddish. And then on another further examination, but there were no cellulitis or anything initially. But later on, we have noticed that he had some skip lesions. So I'll show the picture of this thing, but it was later on. This was like after 48 hours of initial examination. So he had, initially this area was only showing some amount of reddish discoloration, and everything was like plain or normal looking. And directly he had some skip lesion over his thigh, the medial side of thigh. And the leg was mildly swollen and no crepitus, means this is after 2 days. And there was no crepitus on examination. And the crepitus was elicited up to the anterior abdominal wall subsequently, but 6 bottles of bacterial blood culture. So you need to send more and more blood cultures, especially in these kind of patients who have fever for more than 5 days or so, and you don't have a clear-cut diagnosis or focus of infection apparently. And his CPK levels were also high. A clinical diagnosis of necrotizing fasciitis was done, and immediately fasciotomy was done. Antibiotics were changed to penicillin and linezolid. IVIG was also advised, but they were not, because of financial issues, it was a very costly affair. And later on, he has been, debrided, even bedside. Means you should not even wait for any kind of sonography or any CT or any test. Means on clinical examination, if you see that there is a refractory septic shock, and if you diagnose it as necrotizing fasciitis, immediately, even at the bedside, you can actually actually do a fasciotomy, because there's a building pressure inside the fascia, and there's a necrosis of all the muscles and all the tissues which is occurring, and basically whatever amount of fasciitis occurs, it actually looks very docile on clinical examination, on top examination basically. But if you cut it, the fascia, actually you see that everything is necrosed. And whatever kind of toxin production occurs, that toxin actually causes the refractory shock. It's not just the infection. Maybe, if you culture it, you might not get anything. In only 20 to 30% of the times you get, some kind of organisms like streptococcus or staphylococcus. But predominantly it is more of a toxin production, which actually makes the patient sick. So we have actually, aspirated some fluid and sent for, PCR test. So that has shown that it was a streptococcus pyogenes. So a short note about this streptococcal necrotizing fasciitis. Streptococcal pyogenes invasion and multiplication in the fascia can lead to necrotizing fasciitis, which is a life-threatening condition requiring surgery. So on clinical examination, when on our day-to-day OPD practice, when we see, patients undifferentiated fever, if you are sure that, there's no other, comorbidities and patient has viral, then we usually, just treat them as a viral infections and all. But in those, diabetics, sort of patients with some history of eczema or psoriasis or some kind of, skin disorders, you always look for that, because the point of entry is where they scratch, because the skin is, means it's an unhealthy skin, and when they scratch, actually these kind of germs enter and it can lead to streptococcal necrotizing fasciitis. And streptococcal toxic shock syndrome toxin or streptococcal pyrogen exotoxins and mitogenic exotoxins. These are the super antigens that can activate the large number of circulating T cells to release the pro-inflammatory cells, and that is the important reason for this kind of refractory shock. Skin discoloration, purple or black, skin necrosis, tense bullae or gangrene are sometimes seen. But if you see, crepitus with myonecrosis, it is again goes in more favor of, clostridial infection. Discharge of dishwater fluid, means, dirty colored or dirty smelling fluid when you actually open the fascia, if you see that. And actually, if you, there is a probe test, a gloved finger or a, probe, if you just insert, it will just, without any resistance, it just moves into it. So that is one, clinical sign at the bedside which can be elicited, and you can make a diagnosis of necrotizing fasciitis. Then systemic inflammatory respiratory syndrome, multi-organ failure, toxic shock syndrome, these are some of the complications of this. Laboratory findings include leukocytosis, as we have seen in this patient, it was pretty high. Then elevated serum creatinine for CPK levels is a marked distinction of to non-streptococcal forms of pyomyositis, that is clostridial. Gas in the tissue suggests more of spontaneous clostridial myonecrosis, but here you don't see any kind of gas. If you actually, image this patient's limb, you might not find any kind of gas, because you expect it, such a big fasciitis. This is a medical emergency and requires a prompt clinical diagnosis with the verification at the surgery. So directly you should go for surgery. Sonography, CT or MRI usually reveals the muscle swelling and fluid collection in the muscle compartments. So if prolonged delays are encountered in the pursuit of imaging studies, then proceeding directly to surgical exploration with an initial limited surgical approach for diagnostic purpose is justified. So coming to treatment, early aggressive surgical intervention with fasciotomy and debridement of necrotic tissue is indicated. In some instances, amputation is also required. High dose of penicillin G, that is or crystalline penicillin, 20 lakh units, every 4 hourly, is very important. And here the other important, additional antibiotics to actually neutralize the toxin production, they are clindamycin or linezolid. They are not here as an antibacterial, but as an antitoxin or anti-toxin production. So they neutralize the protein. Because of its greater activity against the large bacterial population in the stationary phase growth, it is more sustained post-antibiotic effect and its suppression of the production of toxin and other virulence factors through its inhibition of bacterial protein synthesis. So these are the important antibiotics to be used. The use of intravenous immunoglobulin as an adjunct in the treatment of streptococcal toxic shock to neutralize the streptococcal exotoxin and perhaps to modulate the host immune response has gained popularity based on retrospective studies. So when there is a refractory shock, you don't have anything to, actually maintain the blood pressure. So in that situation, giving IVIG, but the dose is pretty high as compared to you might have seen people using it in patients with GBS, GB syndrome and all. So the dose is pretty high here, almost to the tune of 150 to 200 units per kg body weight. So if a person is hefty, the dose goes pretty high. So and it's a costly thing. So this was necrotizing fasciitis. Coming to our second case, a 44-year-old female. She was hypertensive and CKD on maintenance hemodialysis, and she was taking maintenance hemodialysis from elsewhere through her AV fistula. So these CKD patients, when they have AV fistula, then they go for this maintenance dialysis twice a week or thrice a week. So she was that kind of lady. Last 4 years. In mid-December 17, she had, so it was, I'm telling the timeline because, that is how it helps to, come to a conclusion or make a possible clinical diagnosis. In December, she had high-grade fever. She was treated with antibiotics. Probably she has taken amoxiclav, and she was responding. She got better. Next month, after a month or so, she was admitted elsewhere again in some nursing home. Sudden onset of involuntary movements of the left upper limb after maybe 3 weeks, and she was febrile at that with her TLC of 90,700. There with cefuron sulbactam for 2 days, and she also received anti-epileptic drugs for simple partial seizures. So she has been seen by a neurologist, and he said it looks like a simple partial seizure. You start her on levetiracetam or Levipil is what is popularly given. So she was discharged at that time because she was feeling better and she wanted to go home. So she has been discharged against advice. On 21st of Feb, so that is again next month, maybe after 3.5 weeks, she had again persistent fever and involuntary movements of the left upper limb, and the MRI brain was done this time. She had subacute lacunar infarcts in the right centrum semi-oval, splenium of corpus callosum and caudate nucleus. If you see in this region, she had, lacunar infarcts. She received multiple antibiotics again in between. She was on amoxiclav, vancomycin with cefepime for 5 days. She was transiently febrile for a few days, followed by again recurrence of fever. So something was going on, for around 2.5 months. And every time she used to take some short course of antibiotic, used to get better, feels better, and again, go back to, again, same kind of situation. So again, back to square one. So in next month, so she had acute onset of blurring of vision, which was for almost 2 days. And she was hospitalized again. At this point of time, she was hospitalized here in Bharati. On examination, she was febrile. She had sinus tachycardia of 110. And her blood pressure was normal, means normal for a patient with CKD. She had grade 1 clubbing. And the cardiovascular examination revealed she had early diastolic murmur over aortic area and pansystolic murmur over mitral area, which was radiating to axilla. So it was a new onset murmur, possibly, because this was the first time we were seeing him, and she didn't have any kind of past record of any chronic rheumatic heart disease or any kind of valvular heart disease. On investigation at this point of time, she had high white blood cell counts with neutrophil predominance. Her platelets were normal. Fundus examination was normal. Chest X-ray was done. That was also, acceptable. So blood culture, that is 2 sets were sent. So almost 4 bottles from, different limbs with a gap of 30 minutes and all. So what was the provisional diagnosis at this point of time? So possibly, some kind of infection which was going on for more than 4 weeks. She was losing weight. She's a patient with CKD who goes to hospital, in and out of hospital, receiving multiple different classes of antibiotics. And this is a new onset murmur on the, the possibility of subacute infective endocarditis is high on the cards. Apart from that, other infections sometimes, like suppose if we ignore that she didn't have, or we don't know that she had any murmur. So, other infections like tuberculosis or brucellosis or some kind of, bacterial infection. Sometimes AV fistulas, they get infected, they get seeded with, germs. So whenever they go for, dialysis, they get fever and rigors and chills. And these are some of the important differential diagnoses, for fever which is going on for 4 weeks. And she never underwent any, smart investigations actually, because, every time she used to refuse that I don't want to get done and just treat me with some kind of, medicines. So to call it as a Pyrex of unknown origin, again a debatable thing, because there you need to be actually investigating a patient pretty smartly, or hospitalized after. So 2D echo was done at this point of time. She had this abscess on her mitral wall, which was 1.5 into 0.8 centimeter on anterior mitral leaflet here in this region. and one vegetation on the posterior mitral leaflet, so somewhere here. And aortic valve, two vegetations were seen on aortic valve. Again 0.8 to 0.5 centimeter, 0.7 to 0.3 centimeters. And she had a severe aortic regurgitation. So minimal pericardial effusion was seen, mild concentric LVH, mild dilated and moderate MR, and ejection fraction was normal, that is 55%. So, so again this time, she had this blurred vision, and she had this neurological new entity. So again MRI brain was repeated here. So she had this recent watershed infarcts. Bilaterally in parieto-occipital and right high frontal and centrum semioval region. So in this region and somewhere here. Multiple bilateral hyperintense foci suggestive of old ischemic lesions. So this time she was referred for an ID opinion. So so for infective endocarditis, we always look whether she is fitting into modified Duke's criteria. So when we talk about modified Duke's criteria, we talk about definitive infective endocarditis, possible infective endocarditis, or infective endocarditis rejected. So you need to have those some of the clinical as well as laboratory criteria. So as per the modified Duke's criteria, she had possible infective endocarditis because she had one major thing, that is 2D echo evidence of vegetation and an abscess, and two minor criteria, that is fever and embolic episodes. So impression was possible infective endocarditis, where blood culture was still awaited the report, with cerebral embolia in a patient on maintenance hemodialysis. So this was a working diagnosis we do. So whether this patient should go for an early surgery, because she had, remember there is an abscess. So wherever an abscess, always think of the source control, because unless otherwise you control the source by draining the abscess or by operating anywhere, means wherever possible you should do it. Wherever it is difficult, still you should do with imaging guided abscess drainages and all. So whether she should go for early surgery, because nowadays infective endocarditis, when we diagnose, it is not a medical diagnosis, it's a surgical diagnosis. So always all patients with infective endocarditis or suspected infective endocarditis should daily be assessed for whether it's a definitive endocarditis or a possible endocarditis. Or you should reject the diagnosis by proving or otherwise. So when we have described it as a possible, then there are indications for surgery. So valve abscess and suppuration, that is vegetation and there is a pus in the cardiac valve. It could be a indication for early surgery. Severe AR, again that is important reason for early surgery. Refractory congestive heart failure, because she was again breathless and pedal edema and everything. Even after dialysis she was having this fluid overload, and she was definitely into refractory congestive heart failure. And the vegetation on the mitral wall was of more than 10 millimeters. So these were some of the indications for the early surgery in this lady. Which were the criteria which were going against the early surgery? That is more than 2 centimeter non-hemorrhagic cerebral infarct. So patients who have infarcts along with infective endocarditis, because these emboli, they just dislodge and get into brain or any part of the organ system like lungs, kidneys and spleen. You might have seen splenic abscess in patients with endocarditis. So especially hemorrhagic, non-hemorrhagic cerebral infarcts, of course it's a contraindication, but you need to see that the dimension is more than 2 centimeters. Infarcts in occipital lobe, it's again a contraindication, and double wall replacement required, again a contraindication. So due to the risk of hemorrhagic transformation of the cerebral infarct, we chose to start antibiotics and defer surgery for at least 15 days with close clinical observation in the hospital. So likely organisms in this patient. So whenever you diagnose a syndrome in infectious diseases, always think of what could be the possible organisms in these kind of situations. And then you can choose a particular antibiotic depending on that. Suppose, for example, not in this case, but just a general example. Suppose a patient with say a lower respiratory tract infection comes, or a possible pneumonia comes. So we should always think whether this patient has come from community, or whether this patient has come from a nursing home, whether this patient is in and out of the hospital for last 3 months, has he received any kind of antibiotics in last 3 months. Depending on these, some of the important questions or comorbidities, we can always think of possible organisms. So when you actually make a fair clinical syndrome and guess of a possible organism, then depending on that you actually investigate or choose an antibiotic. Rather than there's no clear cut like earlier we had, say upper respiratory tract infection hai, चलो azithromycin से ठीक हो जाएगा तो possibly or some kind of second generation cephalosporin like oral cefuroxime or something. And थोड़ा LRT आया है तो चलो ये यूज करते हैं. As म्हणजे these kind of things are not possible nowadays because with increasing drug resistant, multi-drug resistant organisms and people taking over the counter antibiotics, because before coming to you also they might have used your old prescription and tried those things. अरे मागच्या वेळेस सारखाच प्रॉब्लेम आहे, so we'll just try this. After 3-4 days they will come to you and say की ते सगळं ट्राय केले, now what should I do? So that situation is increasing nowadays. So always make a clinical diagnosis, working diagnosis, and think of possible organs. So in this patient, the likely organs in these patients were like Staphylococcus, MSSA and MRSA, because mind you, she goes to hospital for hemodialysis, and hospital acquired MRSAs are pretty common in these patients. Other thing is Enterococci. Enterococci is again a typical organism, can cause infective endocarditis, especially patients who are undergoing some kind of urological things, like hospitalized, they put the Foley's catheter and all. So those organisms, Enterococci, from the urine tract, they can, translocate into the blood, and with the defective walls, they can go and stick there and cause endocarditis. Gram-negative organisms, bacilli, like Pseudomonas, is again very common, hospital-acquired bug. See, she is not directly from community, but she is kind of, hospitalized patient, because 3 months, she is always receiving some or the other antibiotic. And antibiotic regimen, the sidal means when you choose the antibiotic, especially in infective endocarditis or bloodstream infection, you want the combination which can kill the organisms rather than just stop the growth or anything like that. And when there is an infective endocarditis, it's a very tight kind of situation. So it's like the mega cities of the bacteria. In a small area, there are millions of bacteria. They are making their colonies there. So for antibiotic, we need to choose which can actually penetrate into those kind of things. So for pneumonia and all, suppose if we consider that as a village of bacteria, like, because it's not tight situation, but the valve, involvement is like a very densely tight. So she was started empirically on daptomycin with a renal dose modification in meropenem, because we thought of all these organisms, and before we get the reports, we wanted to cover them. So why daptomycin? Because it was equally effective against MSSA and MRSA, that is methicillin sensitive Staph aureus and methicillin resistant Staph aureus. They are totally different organisms. असं नाही की म्हणजे मेथिलिन सेन्सिटिव्ह आहे आणि खूप आपण त्याला ट्रीट केलं सेफॅझोलिन किंवा ह्याच्यानी आणि थोड्या दिवसांनी ते रेजिस्टंट झालं, असं म्हणजे युजली दॅट हॅपन्स इन ग्रॅम निगेटिव्ह बॅसिलाई, वेअर विथ कॉन्स्टंट यूज ऑफ सम ऑफ द अदर अँटीबायोटिक्स सबऑप्टिमली they can become actually resistant, or resistant colonies can develop among those germs. But Staph aureus is an organism, and these two organisms genetically different. And vancomycin is inferior for methicillin sensitive MRSA, and teicoplanin has a poor valve tissue penetration, so we chose daptomycin. And later on we got this report telling us that this was an Enterococcus faecium. So Enterococcus faecium is one of the most difficult organisms, to be treated. And infective endocarditis with this Enterococcus faecium, you might have heard of Tamil Nadu CM Jayalalitha. She had same organism, and she had infective endocarditis in fact, and she has succumbed to that. Because if it is sensitive, then it's a very good organism to be treated, like with just ampicillin and gentamicin, with very inexpensive. But even though for infective endocarditis, even though you use these combinations, they should go for surgery, because Enterococcus is such an organism that practically no antibiotic can kill it. So if you see here Enterococcus faecium, she had gentamicin. We always look for gentamicin. Can it be used along with ampicillin? And it was sensitive here. So, when it comes to infective endocarditis with Enterococcus, you need to always check for penicillin, MICs and all. I'll skip this because this is too much of this thing. So, blood culture was positive for penicillin resistant Enterococcus faecium. So, she was treated with vancomycin and gentamicin. The repeat blood culture on 8th day of antibiotic was sterile or negative. Dyspnea, hypoxia, LVF, and requiring daily hemodialysis. And on day 13 of post-infarct, she was taken up for double valve replacement surgery. Intra-op valve cultures were sterile, and post-op she had an uneventful so what is the take home here? Delayed diagnosis of infective endocarditis patient on hemodialysis with PUO or kind of PUO and embolic episodes. Always think of infective endocarditis, or at least talk to your clinician that just check for infective, because I have been seeing this patient, because most of the times they always come to their family physician first for anything. So always keep this in mind. Indication and optimal timing for surgery in infective endocarditis with cerebral emboli is again a issue needs to be closely observed. So these were my bigger cases, but smaller cases like pictorial cases, I'll just go to this now. 37-year-old carpenter, a teetotaler. He was not drinking or no any kind of habits. Fever, chills for 2-3 days, pain in the throat, mild dry cough, uneasiness, and he came to emergency at 11:30. Seen by emergency physician, his temperature was 100.6, awake, oriented, anxious, and saturation was okay. He was admitted in room, ECG was normal, and CHOP was negative. TLC was 12,600, 87% neutrophils. His dengue, malaria, well Felix, all were negative. Urine routine examination was normal, chest X-ray was normal, blood culture was sent and it was awaited. So provisional diagnosis of acute tonsillitis was done, because there was throat and some swelling over the tonsils, and he was started on IV fluids and IV amoxicillin. So next day patient was afebrile, counts were 8,700, but now he developed abdominal discomfort. So physician thought it's more because of the amoxicillin, because they can develop this kind of GI problems. Per examination there was tenderness, and sonography was showing again here appendicitis. So this time basically the fever was there, and thought of tonsillitis, but sonography shows the suspicion of subacute or acute appendicitis. General surgeon was takes him for appendicectomy, because if you refer to a general surgeon, quickly they would like to, for appendix, quickly go for appendicectomy. And surgical resident says patient looks a bit means basically he was anxious and he was not able to tell what exactly is happening to him. So resident was like probably patient has some psychiatric problem, and he's like very much different. His heart rate, if you see, it was 130. Saturation was 90%. Post-operatively, post appendicectomy, he was kept in ICU. This was in some other hospital, before coming to us, we have seen. Later on, we came in picture. His ABG was suggestive of hypoxia. His echo was showing, RARV dilated, and he has a pulmonary systolic pressure of 90. So actually, they didn't think that, to need for any 2D echo or any workup for before the appendicectomy, because he was a young chap. And so then they thought possibly, he might have developed pulmonary embolism, because right arterial and venous ventricular dilated. And lower limb Doppler was done to check any DVT. There was no DVT. And CT scan of pulmonary or CT pulmonary angiography was done. There was no evidence of any pulmonary embolism. The next day, his heart rate was again 134, abdominal soft, mild tenderness. Again, he was, started on some kind of medication for pulmonary hypertension, macitentan. Repeat echo was done. This time, the pressure from 90 it has come down to 70. And because of the, high heart rate and all these things, we asked for a thyroid function test. And if his TSH was 0.09, it was very low. So possibly he had thyroiditis, and he was started on propranolol orally. And I think I just missed that step. So propranolol was started, and patient actually responded. Within 8 days his pulmonary arterial pressure has come down and everything. So basically he had acute thyroiditis, which was causing fever and these kind of problems to him. And possibly that appendicitis was more because of inflammatory change, and it may not have needed any kind of appendicectomy. So actually he was been brought from the hospital with IV lines and everything in OPD, and we have asked for this test. And with for thyroiditis and all, sometimes they require oral steroids, short dose of oral steroids for a week or so, and you need to actually follow them up, because they might develop hypothyroidism later on. So this was a case of acute thyroiditis, mimicking tonsillitis and appendicitis and going for appendicectomy. So this was a learning, kind of case. And if you see, these patients actually goes into Graves' disease and they can die on table. So this is a very grave problem. And simple clinical examination like checking the pulse, because in any fever and all, you hardly see any tachycardia of this level, 130 and 120. So always you should, look for thyroiditis as one of the important causes for fever and tachycardia. So, this is a short case again. She's a lady from Ahmednagar. She was HIV positive, and she has been taking, all this treatment for almost 10 years. And recently, for some, anemia, she has been changed her antiretroviral therapy to this TLE. TLE is efavirenz-based antiretroviral therapy. Earlier, she was on stavudine, lamivudine, and nevirapine. And stavudine and zidovudine actually causes anemia, so it has changed to TDF, that is tenofovir, lamivudine, and efavirenz. She had mild fever and breathlessness. So she was like any other immunocompetent patient. And she had this problem, of HIV. That is why she came to us, because she was on regular treatment with us. And she had dyspnea, which was worsening over 4 days. And she, just had a mild fever for a couple of days. She said, no, there was no much of fever, but, later on I was feeling very breathless. So she directly got into the ICU, and she was already on noradrenaline and BiPAP. She was continuous hypoxemic. So something, which has acutely, occurred. So basically these kind of situations usually you see in pulmonary, and so we, worked up her for alcoholism. But only apart from, severe metabolic acidosis, she didn't have anything. So these patients, sometimes can develop something called as Fanconi's syndrome. That is because of the TDF, that tenofovir medication of HIV. They develop something called as renal tuberous acidosis and get into metabolic acidosis. We checked that as well, so she was not having all these things. And clinical examination was unremarkable. And PCP is Pneumocystis carinii pneumonia, which is common in patients with HIV, especially if the CD4 count is less than 200. But her CD4 was, absolutely normal for her status. And was there any abdominal sepsis? But while working, on the second day, we have seen that, she had this rash. So this was very interesting, and, rarely you see this kind of, distribution of the rash. So this is very typically seen in, meningococcemia actually. So we thought of, that was our first differential diagnosis, and we immediately wanted to send the blood culture. So blood cultures were already sent. But when on inquiry to our ICU registrar, and we have found out that she actually received a dose of cefotaxime, and then the blood culture was taken. So even a single shot of, cefotaxime or ceftriaxone can, make the blood culture become negative. So if you want to prove it, actually, you can take the sample from the lesion and culture it. But that will be like kind of a biohazard, because, it is very infectious. And then when we see this, we have actually gone back to her relatives and, asked about the history. And they said, yes, means, we have found out that in our vicinity, or, त्यांचा वाडा म्हणजे नगरमध्ये, and the वाड्यातले लहान मुलं एक आजारी आहे, possibly meningitis, and is very sick. आणि आणखी एका जणांना असं टाईपचं fever आणि हे आलेलं आहे. So it always comes in clusters. So that history is very important. So then, we were pretty sure that this is definitely meningococcemia. And we have actually asked for meningococcal PCR test, and that has come positive in the next day. So just simple, treatment with ceftriaxone and vaccination to the close contacts who are not ill, and people who have actually nursed her or came in close contact, you need to actually give the chemoprophylaxis with, oral penicillins or ampicillin. So this was a quite interesting case, because nowadays you don't see of meningococcemia, and everything was fit. Means, the rash, the history. So this was again a short case. A farmer from Fulton, he presented with fever, body ache, nausea, loss of appetite for a week. He has seen his, doctor in Fulton. He took treatment with chloroquine, diclomol, and ciprofloxacin was, taken. He was better for a couple of days, but he developed, breathlessness and generalized weakness, and found to have hypotension and shock. And then he was, shifted to one of his son's house in Swargate, and they actually hospitalized this patient here, female, sorry. She was hospitalized here in Bharati. So on examination, she was found to have anemia, hepatitis, there was some pneumonitis, platelets were low, thrombocytopenia, leukocytosis, hemoglobin was dropping, her CRP was positive, procalcitonin was high. So everything was, fitting in, some kind of sepsis which is going on. But her routine tests like malaria, dengue, well Felix for rickettsia, leptospira, then all of them have been negative. Actually, somebody has sent her throat swab also for H1N1. That was also negative. She was given piperacillin tazobactam, Fluvir was continued for 5 days, doxycycline for 3 days. Peptazo and Fluvir. And, within, after starting the doxycycline, actually she was off inotropes and she actually was extubated. So this was, sort of retrospective or empirical use of doxycycline. But when actually we have been referred, we have been referred for this actually. She developed actually, they were trying some arterial line and she developed this kind of big thrombus which was causing gangrene. And nobody actually has examined her legs and all, but we just undressed her and we have examined. She had digital gangrenes actually, and that is how we wanted to do her rickettsial test again, because it was negative at 2 occasions earlier, and we have repeated, and this time the titers from 0 it has come to 1:80, and this actually proves that this was actually rickettsial infection. And if you see in the literature, digital gangrenes are pretty uncommonly, described with rickettsial infection. So rickettsial infection is basically a vasculitis. So wherever there are vessels, older physicians, in your days you might have seen patients with syphilis. So syphilis is again a kind of vasculitis. So wherever, you can have neurological problems, you can have cardiac problems, you can have gangrenes, vasculitis, GI bleeds, then acute kidney injuries and so rickettsia can cause, especially the scrub typhus variety can cause digital gangrene. So this was treated. With again the vascular and plastic surgeon. But in this thing you cannot do anything because these are dry gangrene, and they actually later on auto amputate. She will come for follow up now. And we might see that, this is all amputated on its own. So, thank you. So, I thought, these are the variety of cases and a lot of other interesting cases. I didn't have the photographs, so I thought we should have some photographs and also it makes it interesting. So, simple means office practice we see rickettsia, but, it is an extreme complication of rickettsial infection. So, pneumonia, thrombocytopenia, leukocytosis, GI bleeds, then acute kidney injury. They can have aseptic meningitis. We had a patient with aseptic meningitis. Means everything was normal, but patient was totally drowsy and comatose. But later on, but again the drug of choice remains same: doxycycline and azithromycin. Sometimes in kids where you cannot use doxycycline. In certain situations, in Oriental countries, some of Indonesia and all, they see a lot of rickettsial infection and they have reported some doxycycline resistant cases. So in those situations, they have used rifampicin as one of the things. Because, these kind of patients, sometimes when they come from especially Solapur and त्या एरियातले जेव्हा येतात तर बेसिकली प्रोलॉंग ड्युरेशन illness असेल तर they will be started on AKT. So sometimes with rifampicin they actually get better. But again it is a very difficult task to stop the AKT which was already started. So we have to actually investigate and do a lot of counseling with the patient to stop it. And initial phase, rickettsial PCR is one of the important tests which you can send. In initial 3-4 days, if you send it, it comes positive. Because during that time, Well Felix has got a very low sensitivity. So it doesn't come positive. And in given clinical situation, rickettsial, titers, even 1:40, which usually labs, send report as negative, that still, should be considered as positive because it has got a good positive predictive value. So that is why you should actually request your lab to actually give the titers rather than just giving it as positive or negative. And let the clinician decide what he wants to interpret from that report. So any interesting cases if you have, you can. This patient, rickettsia? No, the previous case, the infective enterococci, okay. Huh. Yes. Gentamicin is actually, can cause renal toxicity. But if you see this patient already has, fired kidneys. It's for 5 years. And Enterococci faecium is such a deadly infection, which is a killer infection. And if you have a gentamicin, so that is why we have specifically asked for this test, the synergism. So in that situation, gentamicin, initial 5 days of use of gentamicin along with, ampicillin actually gives the best sidal reports. And she was already on dialysis, and so we, used to use it and then dialyze it basically. So gentamicin, amikacin, these usually are being used as single dose antibiotics because, they have Cmax above MIC as their mechanism for PKPD. But, gentamicin when you use for sidality or in combination for synergism, especially in infective enterococci, gentamicin is used thrice a day. So we have modified the renal dose and it is just for initial 5 days. Later on it doesn't, help. No medical use. When you have Enterococci faecium, nothing works for that basically. So whatever, best you can do, she should be alive, then only you can talk about her kidneys and all. But otherwise gentamicin and these things are nephrotoxic, and people with normal kidney function, you have to be very cautiously using them. For someone who's on 5 years, hemodialysis, not a big issue. Because we could save her basically. Not able to actually take her for operation in initial 2 weeks because of her cerebral emboli. And we were actually pushed and there was nothing. But luckily we got, this as a organism. Otherwise, if you don't get organism in cultures, then again, problem. So that is why, it is advisable to send more volume of blood culture, especially in patients who are running, fever or undiagnosed for many days. Because in single bottle, they take 8 to 10 ml of blood into those Bactec bottles you might have seen. So that gives yield of around 20%. If somebody has never used an antibiotic in last, say, a week or so. But if you increase the volume to up to 60 ml to 80 ml with, multiple bottles, the yield goes up to 80%. So that is why very commonly, the commonest organism we get in patients with fever and all is Salmonella typhi. Because if you send, 2 or 3 blood culture bottles, the chances of getting Salmonella typhi are high. It's a predominantly an intracellular organism. So you need to send more volume of blood culture. एक सॅम्पल जर असं पाठवलं तर त्यामध्ये मोस्ट ऑफ द टाइम्स येत नाही. पण दॅट इज वाय वी कॅनॉट से दॅट इट इज निगेटिव्ह वगैरे. येऊ शकतं पण त्याला मग खूप प्रोलॉंग्ड इन्क्युबेशन वगैरे 15 दिवस. पण कुठली लॅब असं युजली ठेवत नाही बिकॉज दॅट रिक्वायर्स लॉट ऑफ स्पेस फॉर दॅम. And if their volume is much, they usually take it out within 48 hours, the bottle, blood culture bottle. So specifically, त्यांना सांगितल्यानंतर ठेवतात. See, basically, for anti-tuberculosis or ATT, there is something called as category 5 in RNTCP, where, you are justified to use AKT, but, you should have a proper clinical syndrome for, those kind of situations. If you say, you should actually investigate that patient more, image them. So you will definitely find some of the other lymph nodes somewhere. Try as much as possible to take the samples. If you are not getting sputum, then, try to see whether there's any lymph node, proper clinical examination. Sometimes if you are, in suspicion whether, it's a lymph node or something else, especially in the cervical axillary region, you can do sonographies and sono-guided true cut biopsies or FNACs. At least you should try for a microbiological diagnosis first, and not mere, just seeing the AFB is enough nowadays. because you might have heard of, MDR or XDR, extremely drug resistant TB. And unlike, like what was there in before 20 years or so, the MDR rates and XDR rates have gone up to 22 to 27%. So patients who never had TB, but coming to you and you have diagnosed them TB microbiologically, and there are 1 in 4 patients can have a MDR TB. So that is why doing drug sensitive testing is the most key factor nowadays in this era. But at least if you see the AFBs, then definitely that's a very good this thing. But now new tests like CBNAT or Gene Expert, that is a very classical or good test, and it has been recommended by WHO and accepted by RNTCP, Government of India, because within 90 minutes it gives you the results whether this is TB or not TB, and if it is TB, whether it is rifampicin sensitive or not. Because if you have that information on your hand, and you can confidently start the treatment. Because you might have seen, even after starting AKT, patients will have some or the other kind of fever or some symptoms at least for 2 to 3 weeks. But when you are sure that this is TB, then you can tell patient that nahi, घ्या तुम्ही औषध 2-3 आठवडे. Otherwise, if you are not sure, then again will be on a shaky ground actually. Because AKTs, they have a very toxic effect. So I have seen one patient, empirically started on AKT and INH induced fulminant hepatic failure, and patient died actually. Just 1 tablet of INH and idiosyncratic reactions and dead eye. So we should be very, very careful, when we actually, because it doesn't take even 30 seconds to write an AKT for a patient, but it's a very thoughtful process, I think. And when you have actually imaged everything you have seen, nothing is, you are finding anything, then think of, other non-infectious causes as well. Sometimes connective tissue disorders, like adult onset still disease, can come to you as just fever, which is not going. And because, there the treatment is totally different, because you need to give them immunosuppression. So if you just give anti-TB treatment, they are not going to get better. But there is a category, and medically you are justified, in given clinical situations to start AKT empirically, even if you are not having any microbiological diagnosis, but at least try for even histopathological diagnosis, like कुठं granuloma वगैरह जिसको होता है. And TB असं नक्की म्हणजे they will have some of the other focus. You have to just try to find out. Initially, she might have had actually, but this was when she had this gangrene. That time she didn't have any typical rash or eschar. This was actually iatrogenic. Means they tried to put a arterial line, and actually she developed a thrombus there. But they thought it is purely iatrogenic and nothing to do with her basic disease. But when we actually examined her thoroughly, and we could see that digital gangrenes on the toe. So that means that she had that tendency of developing gangrene, and this was just a trigger initially on the hand. But initially on clinical examination she might have had, but we have checked her general practice, GPs, her family doctors case records, but there was no mention of any rash or anything. See, in our small audit, what we have done in last 1.5 years. So undifferentiated fever without any focus when they are coming. So our highest rate of the diagnosis was typhoid fever, that is up to the tune of 32%, followed by rickettsial fever. So rickettsial fever and typhoid fever, these are very common two infections. Almost 50% patients with undifferentiated fever, especially fever going on for more than 3 days or so. Then definitely these two diagnoses should be kept in mind. Apart from, of course, viral fever and all. And this initially very is closely mimic like viral fever, because body ache, fever, sometimes even they get URTI kind of symptoms and all. But if you take their history, means travel and where they stay and all, especially from rural area and even urban areas like slum dwellers or compact living situations, there definitely you should think of rickettsia. Because rickettsial fever has got different types in itself. So scrub typhus is very common in rural areas, especially farmers who are staying in the farmlands and all. And Fulton, then and especially this big one and all. These areas have a lot of rickettsial infection. Not lower substratum, their habitat. And so they have, from this thing, this big one and all, they have reported even cases with arthritis and all, with scrub typhus. But if you examine, almost 20-25% of the times you can find an eschar. Eschar is like, cigarette burnt appearance kind of this thing. And it is more in the hidden areas like axillae, breast fold, gluteal folds, back, inside of the thigh. So properly examination required in these patients. I think I'll stop here.